Good morning, everyone. I was going to ask, can you hear me? But that would be a crazy question, wouldn't it? This is really booming, isn't it? Um, Look, Byd-eang Pub, everyone, a very good morning to you. I am really excited to see such enthusiastic turnout for this conference. We have lined up what I hope is very good presentations and conversations today, and I look forward very much to leaving at the end of the day both challenged and inspired in equal measures. I think the last time we had a conference in Wales Africa Health Links Network was 2019. That was before COVID. And I think it's probably the right thing to just spare thoughts for everyone who has, in the last 2 or 3 years, suffered, whether personally or in loved ones, family, with COVID. For those of us who were at the forefront, if you like, of the fighting COVID, it was a very difficult experience for many people. And I hope that as we hopefully recover from COVID and begin to find those connections and links once again, that it will be recovery into a better world. We have themed this conference today around the subject of empathy. I wouldn't be surprised if in the course of the day we hear about compassion as well, because they are quite related, if not perfectly overlapping concepts. So please bear with me as I attempt to set the context with socializing our thinking behind this theme. Although I'm a storyteller by nature, I do joke that the art of storytelling was probably taught out of me many years ago when I went to medical school. So I have somewhat been on a relentless quest to resurrect that storyteller. So here goes. I grew up in Nigeria, a middle child in a family of 10. Resources were very hard to come by, and there was a small but definite element of survival of the fittest when it came to the access to the family's common wealth, by which I mean food. Perhaps more accurately, there was food, but it was often without a key component, which in our time was meat. I wasn't the loudest, quickest, or most physically gifted of the children, which are all attributes that you need to get a good share of the little meat that went around. So what did I do? I devised a strategy as a young child. I realized that I could tell extemporaneous stories, which my siblings and other children from the neighborhood would sit around and listen to with rapt attention. So what did I do? I exacted a commitment from every one of them. I would tell them stories for a little piece of everyone's meat at dinner time. So I think that's probably why my first bit of serious research was on bowel cancer screening, which I see as my personal protection plan against the consequences of an early life course of overconsumption of meat. I carried my interest in storytelling into medical school, so an early encounter with a wise old professor of medicine became pivotal in my early career direction. He said more than a few times, when you become medical doctors and you have a patient before you, always ask 3 questions of yourself. Why this patient? Why this disease? And why this time? Now, obviously, at that time, I didn't understand what he was talking about, but when eventually I understood what he meant, it led me to a career in epidemiology and global health. I understood that those questions that the wise old professor was asking us to ask as medical doctors, which fits neatly into epidemiology's paradigm of determinants and distribution of disease states in populations, were really about empathy. Those questions were really about understanding the whole story behind the patient's presentation. In the words of Robert Center at the University of Alabama, to be a great physician, you must understand the whole story. Empathy, which we define as identifying, understanding, and sharing in the feelings and perspectives of other people, whilst maintaining that self-other distinction, is really about understanding the whole story. So it's no surprise that my love for storytelling meant that I responded very positively and quite instinctively to the advice from the professor. If empathy is about understanding the whole story while walking in the shoes of another, then it's hard not to see a deficit of empathy at the roots of much of the very challenging social disruptions we see in our world today. And I'll take a few, for example. Political turmoil. Now, whether it be Brexit or the global outbreak of identity politics. Think about racism and the race injustice that gave rise to the Black Lives Matter movement. What about the COVID pandemic? We saw the lack of empathy that played out in the vaccine wars between the UK and the EU. But we also saw attitudes to mask wearing, displaying how some people absolutely valued personal freedoms over the burden of caring for the health of a fellow citizen. Global conflict, the latest and probably the most potentially far-reaching in consequence of which is Russia's war in Ukraine. And of course, the cost of living crisis being faced by much of the world today. The deficit of empathy does not just drive global social upheaval, but it also shows up as a key determinant of the challenges that healthcare systems are facing daily. As we speak, for example, the NHS in Wales is unrelentingly challenged in respect of elective waiting lists, unscheduled care pressures, and transitions of care from health to social care. For the sake of time and expediency, and before I home in on empathy in health and healthcare, I want to explore two of those social trends that I've just mentioned, political turmoil only briefly, and in a little more detail, race and empathy. When Britain voted for Brexit in 2016, parts of society scrambled to understand what had just happened. A Chatham House analysis by Matt Waldman gave a thought-provoking analysis which essentially drew parallels with the emergence of Donald Trump in US politics. The analysis blamed those incidents, that is Brexit and the emergence of Donald Trump in US polity, on the lack of empathy. It did suggest that those incidents they were at once a reflection of a lack of empathy on one side of the divide and the perverse exploitation of empathy on the other side of the divide for political ends. In a rapidly polarizing world, the skill of grasping what other people are thinking, what they are feeling, and what they are perceiving is becoming ever so critical. Closer home here in Wales, 62% of the Ebble Vale population, for example, where significant EU investment had gone in, voted to leave. The question for me is this: what about their fears, their feelings, and their perspectives, rational or not, had we failed to hear? On empathy and racism, I'm drawn to the distinction between racial discrimination, which plays out largely in interpersonal reactions or interactions, and the more powerful and influential racial stigma, which plays out in more unseen and social and economic processes. Fundamentally, I'm making a very practical distinction between the way a person from a visible minority ethnic group might be treated and the way society structures itself, advertently or not, to systematically modulate access to its commonwealth for those people. I'm interested in this difference because my sense is that racial discrimination, much like a lack of interpersonal empathy, can be tackled by imparting cognitive skills. But racial stigma, on the other hand, and much like a lack of social empathy, has incredible capacity to embed and persist within the fabric of society. For example, despite having above average household income, there are reports that some visible minority ethnic healthcare workers are occupied with how their children might access society's commonwealth. And I'm talking, for example, about doctors and nurses. And that includes education, skills, capital, self-esteem, as readily as other children might do without the influence of race, ethnicity, and other differentiating attributes. These are broadly not concerns in the domain of interpersonal relationships where discrimination might be enacted. Rather, they sit in the more abstract and insidious domain of powerful societal forces. The idea of racial stigma derives from the concept of race as stigma. And naturally, Irving Goffman's seminal work in 1963 is a key reference here. In his book titled Stigma, Notes on the Management of Spoiled Identity, Erving Goffman described stigma as the experience of moving through life with a spoiled identity, a trait that is seen socially as deeply discrediting. He made clear that stigmatization is an interactive social process where the stigmatizer must identify an attribute in a stigmatized person that is deemed as deviant and socially dishonorable. He identified 3 kinds of stigma, the third of which is tribal stigmatization. Goffman used the word tribal in a very broad sense to refer to race, religion, and nationality. But the element of Goffman's contribution to the understanding of stigma that is most relevant to the subject of empathy is in how he advanced the understanding of the fact that stigma is embedded in the social processes of categorization and signification. In other words, society classifies its members on the presence or absence of a specific attribute, and then it attaches to those attributes social significance that can either be discrediting or approving. And whilst the vast majority of human differences are ignored and are therefore socially irrelevant, that is not significant, for example, the color of one's car, others, such as skin color, intelligence quotients, sexual preferences, and gender, appear to be highly salient in society. A desire to understand the more insidious social forces of racial stigma leads one naturally to the work of Graham Scambler, who described 2 dimensions of stigma. The first, which is enacted stigma, is discrimination by others on the grounds of being different. The second, felt stigma, is an internalized sense of shame and a paralyzing anticipation of enacted stigma. And I think this is a feeling that anyone who has ever been a minority on any kind of attributes, whether it's ethnicity, whether it's sexual orientation, has felt. There is evidence across many studies that felt stigma is as damaging to people's lives as enacted stigma. I regard the term felt stigma a bit more widely to capture those perceptions, expectations, and anticipations of stigma, which, despite not being enacted in interpersonal reactions or interactions, are nonetheless so significant as to influence the life chances and the outcomes of those who are experiencing them. Take, for example, the oppositional culture theory, old theory, first proposed by Fordham and Owood in 1986. It suggests that low expectations, quite similar to the forces of felt stigma, lead ethnic minority students to feel ambivalent about school and to disengage academically in the belief that academic achievement is the sole purview of white people and that their own hard work would not deliver the expected rewards. In her work in 2003, Roxana Harlow examined how racial stigma affected the emotion work of Black professors, specifically how students' assumptions and perceptions about the competency of their minority ethnic professors can create that need for additional impression management work, or conversely, emotional labor to shield the professor's self-concept from the negative perceptions of students. Note that none of these examples involves direct acts of racial discrimination enacted in interpersonal interactions, but they show that racial stigma can become embedded, systemic, and persistent, producing effects without the need to enact racial discrimination in those interactions. We're talking about empathy, moving from interpersonal to global, and this is the shift that we're talking about. There are similarities in the underlying mechanisms of racial stigma and the lack of social empathy, but more striking for me is the fact that they mutually amplify one another. It takes genuine empathy to identify, understand, and share those internal social processes associated with a sense of racial stigma, sometimes experienced or borne by people from visible minority ethnic groups. These visible minority ethnic groups make up about 13% of the UK population and about 20% of the NHS workforce. So the subject of empathy is relevant in health and healthcare. We know that empathy is associated with positive outcomes in healthcare, such as improved patient satisfaction, better adherence to treatments, and better pain control. But there has also been a notable decline of empathy amongst healthcare staff in recent years. Reports following clinical malpractices have highlighted the deficits of empathy in current medical practice. We know that. Karasidu and colleagues in their research, recent research, showed that where this deficit of empathy has been seen, it's often less about any kind of innate callousness than it is about factors such as long working hours, understaffing, inability to spend sufficient time with patients, any GPs in the room, increased pressure to meet operational targets, and increased workload. Similar to these comparisons I made earlier between interpersonal racial discrimination and more structurally determined racial stigma, there's a tendency often to direct interventions to enhance empathy towards individuals. And what that does is that it trades off a focus on the role that systems play in facilitating or impeding interpersonal empathy. A system that rewards healthcare personnel, for example, for focusing on the illness rather than treating the whole patient, would reinforce the belief that skills such as empathetic engagement are not valuable or important and therefore should not be prioritized. And that's why the old wise professors admonishing to think about why this patient, why this disease, and why this time was absolutely about hitting the nail on empathy. So our healthcare systems need to become systems and institutions that are structured and organized in such a way as to create the conditions that facilitate empathetic interactions in care delivery. They need to be governed by empathy-producing and empathy-promoting political goals and decision-making frameworks that facilitate empathetic interpersonal interactions in the delivery of clinical care. Specifically, it will make for more empathetic global healthcare systems if, instead of considering healthcare as a commodity to be subjected to market forces and rules, anyone from the United States here? Health was treated as a human right, healthcare as a basic good, and access to healthcare based on need rather than ability to pay. Coming back to the wider social upheavals that a deficit of societal empathy partly explains, there are useful lessons to be drawn from the idea of restorative justice, in which offenders are brought face to face with the victims of their crimes to hear how they have suffered because of them. The victim goes beyond their rage with some understanding and forgiveness towards the offender, and the offender empathizes with the victim, becoming aware of the real meaning of their crimes. When people are brought together in a neutral context with an open, trusting attitude, empathy naturally establishes itself. In a dynamic post-COVID world where we are looking to restore social mixing and regrowing collaborations, it is my hope that we restore the foundations for empathy. This commitment to empathy means we will also need to respond to the current climate emergency by innovating new ways of empathy-building social mixing that does not take a toll on the environment. In my time as chair of Wales and Africa Health Leagues Network, I will be prioritizing working with the charities, trustees, and our partners to nurture empathetic global partnerships built on active listening, trust, and racial justice. In closing, I draw from two paradigms of epidemiology and leadership in pressing home the view that we need to look beyond the individual to wider systems that support racial stigma, addressing the institutional norms and practices that enforce it. The first is found in more recent discourse in epidemiology and public health, where there is an increasing shift away from a focus on the health-related behaviors of individuals towards understanding the causes of the causes, what we call the wider determinants of health that influence those behaviors. The second paradigm is in healthcare leadership, where there is a similar shift away from looking at leadership purely from the perspective of the individual to thinking more about how systems are primed to be well led. In other words, you can be an excellent leader, but if you're placed in a system that is not primed to be well led, you could fail. Whereas you could have an average leader, personally, put in an excellent system that has been primed to be well led, and they will absolutely succeed. So it's that shift from just looking at leadership from the individual perspective to looking at leadership from a systems perspective. And the work of William Tate at the Center for Progressive Leadership is a great reference in this respect. For too long, racism has been seen as an individual bias rather than as a structural and institutional problem. And we desperately need to reframe that debate. So again, in my time as chair of Wales and Africa Health Links Network, I want to think systems and institutions. Engagement with Welsh governments and governments generally and institutional systems will be key to how Wales and Africa Health Links Network evolve from this point. And we look forward to nurturing the emergence of empathy onto the center stage of society and global health once again. Thank you very much. So a bit of further, thank you very much, a bit of further housekeeping from me. So I am really, really excited that we're all in this room together, and I think we're going to have a fantastic day of inspiration, learning, and challenging one another. So in a moment, we will have the opportunity to move into our workshops. I think we're a bit early, and that's fine, so we can probably have a longer break if we want to. The workshops are going to start at 11:20, so please have coffee, have the opportunity to look at the stands. I've just been looking at the olive branch and talking to Rachel and doing fantastic work out there in Tanzania. Please have the opportunity, go around, see what is going on, make connections, because this is very much about making links and connections. But when it's about 11:15, I would ask you to begin to make your way to the 3 workshops. Now, workshop 1 is in the committee room, and there will be colleagues from Hub Cymru Africa who will be ushering you to those venues. So workshop 1 will be in the committee room, which is on the ground floor, and that's going to be looking at empathy through inclusion as healthcare workers, and that's going to be led by Kate Chalmers, fantastic colleague from Tropical Health Education Trust, and Kath Mologo from Hub Cymru Africa. And the second workshop is going to be taking place in the council chamber, which is on the first floor, and that's us, Wales and Africa Health Links Network, and our role in helping you, because as I said, we're coming out of COVID. Wales and Africa Health Links Network is needing to re-articulate and its value proposition. What are we here for? We're here to nurture partnerships. But COVID has caused a lot of disruption in the last 3 years. What is the future? And we want to re-articulate that future with you. So we're looking forward very much to your contribution to that second workshop. And my colleagues from Wales and Africa Health Links Network, Gordon Lewis and Karen Robson, are going to be leading that workshop. And the third workshop that is going to be taking place in the Marble Hall, which is also on the ground floor, is going to be looking at global responsibility through empathetic healthcare. And Sandy Club from Future Generations Commissioner will lead that workshop. And when it's 12:20, we will have lunch. So I'm not going to go through the rest of the program for the day. I think that's enough for now. As I said earlier, welcome once again. I really thank you for taking the time to come. And I hope that every one of us will leave at the end of the day refreshed. Catch some coffee now and say hello to other people. But once it is 11:15, please make your way to your workshops. Thank you.